if that's okay. So yesterday we had talked about the role of specialists, if anyone remembers, and what specialists do we have in the NHS. Can anyone give me an overview of what we had talked about yesterday? Anyone? A bit about what we know the topic, but what was there that we talked about? Anyone remembers anything? Okay, so we talked about the role of specialists and what, yeah. Did anyone want to say something? No? Yeah, so we talked about what a specialist is, the role of a specialist, different specialists that work in, who work in different sectors within the NHS. Then we talked about various types of patients that you would have. So there were old age patients, there were neonates, there were infants. There's a whole lot of details that we talked about. And then the specialists that work within the community or work within a hospital. We talked about primary, secondary, and tertiary care. So all that was all covered. Please have a look at the presentations when they are shared with you on Monday. So yeah, today we'll be talking, this will be the last the learning objective that we'll be covering for this unit. And then on Saturday, that will be the 18th of May, we will be discussing our your assignment to do it, how to submit it. So today we'll be talking about understanding the issues in health and social care. So the first thing that the task has been given to you is to assess the equality of access to health and social care within your chosen country. So your chosen country could be the UK, your chosen country would be anywhere in the world. So the first question is, what causes inequalities? So this is according to research, whatever, this is not something that we are saying, but it's taken from several research papers that have been published within the UK. So health inequalities, they are preventable. They are unjust differences in the health status that are experienced only by certain population groups. It's not all the population that has to face them. So the people who are living in the lower socioeconomic groups. So what do we mean by lower socioeconomic groups? There's a high socioeconomic group within the country. So the divide is really it's really clear. So there's some people who barely can make ends meet. So they are the ones who are within the lower socioeconomic groups. They're more likely to experience poorer health. So health inequalities are not only apparent between people of different socioeconomic groups, they also exist between different genders and different ethnic groups. So there are different ways where inequality impacts people. And there are different reasons behind these inequalities, these causes behind inequalities. They're not just socioeconomic, they're gender-based also, and also different ethnic groups are subject to them. So health inequalities are often observed along a social gradient. So the social gradient means the grades of society or socioeconomic statuses. So there's someone who's from the very low socioeconomic status to a low socioeconomic status to a middle socioeconomic status to a high and then a very high. So as this gradient goes, the health inequalities also vary with these social gradients. So this means that the more favorable your social circumstances are, like your income or your education, the better your chance of enjoying good health and a longer life are. These conditions are known as the social determinants of health. Anyone has any idea what I mean by the social determinants of health? Anyone there? What do I mean by a determinant of health and then a social determinant of health? What is health, by the way?
Can you come again, please? Hello? Hello?
Yes, you may speak. Yeah. Anyone who knows what it means by what do I mean by being healthy, and what do I mean by a determinant or a social determinant of health? Any idea?
Of social determinants. Is that what you're saying?
Yeah. What is a social determinant of health?
Okay. Environmental pollution, good
Okay.
standard of living,
Mm-hmm.
and health is the total well-being of a person, individual.
Mm-hmm.
Yeah, so social determinants are environmental pollution, um, economic situations,
Yes, very good.
access to qualitative health care,
Mm-hmm.
and affordability of it too.
Mm-hmm.
Yeah, so those are my points.
Yeah, thank you. So yeah, uh, uh, some of it has already been discussed here. So it's this, you have your that's a biological determinant, by the way. But your income has been mentioned over here, your education. These are all social determinants of health. So it shouldn't be this way. So health should not be determined by how much you have studied or how much you earn. A disease can affect anyone. A person with a very high socioeconomic status could have just a simple flu, whereas a person with a low socioeconomic status could have cancers, for instance. What makes this difference? Why is this that a person who has a lower socioeconomic status suffer more? The reasons people saw that these things are happening more than they're expected to happen. And it was very bizarre. People could not understand, scientists for years and years, they could not understand why is it that um, some diseases hit some people in the society more, much more compared to the others in the society who are at who have a better position in the society. So they then came up with this circle that I'll just talk about. So the causes of health inequality, they're complex, but they do not arise by chance. So this didn't happen by chance. Nothing of this happened by chance. So the root cause they found out of health inequalities was due to the unfair distribution of power, wealth, income, and they're unjust, sorry, and unfair. So what happened that if people were like if you obviously if you're struggling, if you're from a socioeconomic status, a low socioeconomic status, you might not be able to live in a country that um, has, let's say, um, a country like, for instance, within a country, there's certain, like if we consider the UK, for instance, and we consider some places in the UK, like London, let's say, and we know that it's very expensive living in London. So most of the people who are living there, they don't have, if they were from lower socioeconomic status, it makes life even worse for them. And then what they do, they go and live in some places where it's more reasonable to live, it's more affordable to live, but the health situation there is not very good. So let's say if that person needs an appointment, the appointments are not easy to get there. There's no specialized clinics over there. This happens where there's the living conditions are also not so good. You have lots of problems there, lots of pollution there. The councils don't work there well because they're not being paid well over there, and they know that it's not people from the very high socioeconomic statuses that they have to cater to. It's just the people like us, let's say. So this then gave this thing what we call the health inequalities. It's very complex, and it has within itself. So when you see the core factors, it's age, sex, and constitutional factors. So here you have some biological factors that are impacting. So the age and sex are biology. They're not society things. But then when you see, sorry, I'll have to mute. Then when we see others, we go more beyond this. You have individual lifestyle factors, and then you have social and community networks. These are all much better in areas that have rich people living there and more educated people living there. So it's not going to be there. So you might have, these might be the preference of an individual themselves, but then social and community needs. Now we go beyond the personal needs. We go beyond the person themselves. And if I zoom in here, you'll see in a higher socioeconomic status, you'll have different food and agriculture production. You'll have different education levels. It's completely a different world when you go out there. And that is why it's the best of the best who have the best opportunities, because that's how they've lived. That's how their path goes. Living and working conditions, unemployment or employment, water and sanitation, it's the best in the best places, healthcare services, housing. And then you see the general socio-economic, cultural, and environmental conditions. These are actually these ones. These are the general socio-economic, cultural elements and environmental elements. And then you have community. So the main headings would be this one: social and community networks. They're not very strong in not very poor to live places. And then you have these biological. So all of these would have had have played a role in health inequalities. I'll zoom out again. So what is being done about it, if that is known? And this is quite an old document that is there. So what is being done about it? So ensuring everyone can have access to an equal footing is a key priority for the NHS. So one of the 7 core requirements for implementing improved access as set out in, this is the NHS Operational Planning and Contracting Guidance 2017 to 19. And it is to address issues of inequalities in patients who've experienced of accessing general practice and have been identified by local evidence and put actions in place to resolve it. So this is the document that was produced to work on these inequalities. So, and then if you want to assess the equality of access to health and social care within your chosen country, again, we talk about NHS England. It has also endorsed a research called Patient Pathways with the University of East Anglia. And this will provide resources to commissioners and providers that will help them to consider when inequalities arise when patients are accessing general practice services. There's a small video that I have over here to share with you. Just give me a minute. I've opened it up. Yeah, here. So, yeah. I'll share my screen. Share this, share sound, share. Oh, sorry. This was not something that I had to share. Sorry. My screen is open somewhere else. Okay, here. Yeah, and share sound, share. Okay. I hope everyone can see my screen. So here we go.
NHS England has a mandate commitment to ensure everyone has easier and more convenient access to GP services, including appointments at evenings and weekends. Based on local evidence, services are required to address issues of inequalities in patients' experience of accessing general practice. NHS England has endorsed a patient pathway approach to addressing inequalities, which has been developed by the University of East Anglia. The pathway is part of a new resource that will help commissioners and providers consider how inequalities might arise when people are accessing general practice services. Step 1. Difficulties in recognising health problems. Those who are, for example, socially isolated or with poor health literacy may struggle to recognise health problems. Advertising services and health campaigns can help patients recognise possible symptoms of ill health and when to seek help. Step 2. Deciding whether to seek help or not. Some may be unsure if they should see someone about their problem or may not want to be a bother. Others may be unsure about their entitlements or be unduly worried about the impact of their residential status. People with negative experiences may feel hesitant about seeking help. Services like pharmacists, care navigators, NHS 111, NHS Choices, GP practice websites, apps and other online services can provide help and advice. Step 3. Actively seeking help. Not knowing where to find the right care can be a barrier. A lack of internet access, not being registered with a GP, or confusion about how the NHS works can cause difficulties. For example, some older people may be less confident using technology, and vulnerable groups such as the homeless may not understand their rights on registration with a GP. Others, such as people who are LGBT+, may fear prejudice or discrimination. Active signposting can help people get the right care in the right place at the right time. Care navigators may help patients who find negotiating the system difficult. Step 4. Obtaining an appointment. Obtaining an appointment at a convenient time can be difficult for some who are worried about getting time off work or from caring responsibilities. Access to appointments at a range of times, locations and different types can help, such as appointments at evenings and weekends in centrally located hubs. Improved training for receptionists will help to support patients in accessing the right type of appointment first time. Step 5. Getting to the appointment. Those who rely on public transport may find access more difficult, especially those in rural areas, on low incomes, or with mobility issues. Working with transport services may help. Technology and newer types of appointments such as video consultations, online consultations, and phone consultations mean that travelling to appointments is not always necessary. Step 6. Seeing or speaking to someone in the general practice service. Communication between health professionals and some groups may be difficult because of disability, language, or cultural differences. For example, visually impaired patients, autistic people, or those who have learning disabilities may need longer appointments or wish to attend at a time of day when the waiting area is quieter. Cultural competency training and access to interpreters will help. Undertaking a health inequality and equality impact assessment will help commissioners and providers consider equality issues in improving access to general practice services. For more information on reducing inequalities and improving access to general practice services, visit the links provided.
Yeah, that's about it. I hope that was that was enlightening. Okay. So we'll get back to earlier. Yeah. Just a minute. I'll share my screen again. Okay. So I hope that was clear for everyone. So yeah, back to the point where we were. Then so we were talking about the six steps that the NHS has taken in order East Anglia, the University of East Anglia has taken. So we've seen this video. So what was the main things that they worked on? It was difficulties in recognizing health problems. So they may be socially isolated people who have low socioeconomic statuses. This can be addressed. Or they might have poor health literacy. They might not be able to speak the language. They might not understand their symptoms that are happening with them. So how is this addressed? This is addressed by, you can address these health issues by advertising and making more use of health campaigns. Then there's step 2, where there's the decision to seek help. So if they're unsure if they want to see someone or may not want to be a bother, or they're unsure of their entitlements. They don't know what benefits they would be on, or unduly worried of the impact of on residential status. People who've had negative experiences, their decision to seek help really differs compared to those who know their status and who are obviously well literate, and they know what their rights are, and etc. So this this could be addressed by services like the pharmacists, care navigators. So you don't have to go to the GP every time. Yeah, there'll be care navigators that will be coming to you. The services like 111, NHS Choices, GP Practice, and applications that can help to provide advice. And then the third step is actively seeking help. So some people, they don't know where to find the right help, which can be a barrier. There could be lack of internet access. We've talked the videos talked all about this. No GP registration, confusion about how the NHS works. Some people have this when they're new to the place. There may be older people who may be confused using technology. They're already vulnerable. They might be going through dementia also, and there may be homeless people who may not understand their rights when with registering with a GP. There may be LGBT groups that may fear prejudice or discrimination. So this is addressed by active signposting that can help people get sorry the right care in the right place at the right time. Care navigators may help patient negotiating within the NHS system. And then there's assessing, then there's the fourth step that's talks about obtaining an appointment. So some people, they might work and they might have children, due to which their appointments might be hard for them to get appointments. They might be worried about getting time off or from carrying responsibilities. They might have older people they're caring for. So this can be addressed by evening and weekend appointments. So there may be a range of locations that have improved training of our receptionists, which will also help to support patients to access the right type of and convenient appointments. And then step 5 is getting to the appointment. So those who rely on public transport may find access more difficult because if they're in rural areas, low socioeconomic statuses, and for those who have mobility issues. So if they want to get to an appointment place, hard for them. So there may be new technologies that have enabled new types of appointments, such as video consultation. So you don't need to be there. There may be online consultation, phone consultation. You don't have an internet service there. This means that traveling to appointments is not always necessary. And then the sixth step is general practice interaction. So communication between service users and health professionals is sometimes very difficult. Language barriers. They may be visually impaired patients, autistic patients who have learning disabilities, and they may need longer appointments, more longer follow-ups, or wish to attend at a time of day when the waiting area is quieter. So this has been addressed by cultural competency training, which covers areas like dress, customs, behavior, language, religious beliefs, worldviews, kinships, relationships, and values, also interpreters. And then we go on to explain the current public health issues within your chosen country. Public health has been defined as the science and art of preventing disease. So like medicine treats a disease, people working in medicine or surgery, they treat a disease, whereas public health is the art of preventing that disease from actually happening. So if you prevent that disease, not going to have the burden of carrying the disease, and then the burden goes on the NHS also because of obviously more treatment facilities that should be there, more there should be more follow-ups there. So if you're just preventing the disease, but it's hard, obviously, prevention is just word. It's hard to get to that level, but we're trying. They're trying their best. So this is by prolonging life and improving quality of life through organized efforts and informed choices of society, organizations, which include public and private communities and individuals. So they are analyzing the determinants of health of a population and the threats it faces in cases of public health. So public health can be as small as a handful of people or as large as a village or an entire city. In the case of a pandemic, it may encompass several continents. So within the public health group, there were people who worked day in and day out just to combat that situation. So the concept of health takes into account physical, psychological, social well-being. If we explain the current public health issues within a chosen country, so if we talk about the UK, their vaccination programs, so this also comes under public health. So vaccination is the administration of a vaccine, we know, and this helps with immunity. So you have different sorts of vaccinations given during different times to different patients, or healthy people also get vaccines. So they contain, this helps them protected from disease. So vaccines contain a microorganism or a virus. So it might be a bacteria or a virus that has been changed. So it will be weakened. So it's not going to impact your body the way a microorganism, if it was alive, it would have done. Yeah. So it's a weakened live. It might be live or killed. So that organism is live or killed. So for influenza, for instance, the flu vaccine contains a live vaccine. So it's a live vaccine. That means the flu virus itself is there, that vaccine, but it's changed, it's weakened, it doesn't have the same properties, or it doesn't have the same impact on your body as it would have been if it was in a stronger state. You could have proteins or toxins also from an organism. So an organism has proteins, toxins, other parts or other components also within themselves. And these may also be used in producing a vaccine. So in stimulating the body's adaptive immunity, they help prevent sickness from an infectious disease. So they are administered at several stages of life. So vaccination is HIV, this is for pneumonia, this is for meningitis, this is for tuberculosis, coronavirus, measles, mumps, rubella, measles alone, mumps. Okay, so this is measles, mumps, rubella, and MMR. Hepatitis, varicella, this is for chickenpox. So they're administered at different stages in life. So there are some people who have weak immunity, so their immune system is not very strong. So it's diabetics, you have pregnant women, you have HIV patients. So these vaccines there are different vaccines that would be used in them. So not everyone will be subject, not everyone will have to receive these vaccines that we mentioned earlier. So we talked about contraception. What is contraception? It's birth control. It's anti-conception. So, and fertility control is a method of or a device that is used to prevent pregnancy. So you're not going for abortion. That's another way to prevent life from happening, but that's a more advanced stage. You don't want to get to that stage. Before that, you want to prevent even the origin of a human being. So for that, you go for contraception, where you are preventing the birth from happening. So these are birth controlling mechanisms that were used since ancient times, but effective and safe methods of birth control only became available in the 20th century. Otherwise, they were very dangerous. That would be life-threatening for, like abortions themselves. They were considered as birth controlling methods, but it's not true. Contraception is a core public health issue, and it has potential to reduce family size, improve birth spacing. So it's birth planning, isn't it? It's family planning. How much do you want to have? How many children do you have? It's how many children do you have want to have within 10 years of your marriage life, for instance. So that's birth spacing. All of that comes into family planning. So this will in turn lead to better health outcomes for the infants, children, and for the woman and themselves. So, and then we talk about healthy eating. So, Public Health England encourages organizations and individuals to use Eat Well Guide. It's a guide there to make sure everyone receives consistent messages about the balance of foods in a healthy diet. Excuse me. And there's preventive health campaigns. So, public health campaigns involve the dissemination of information to the public to help groups of people resist imminent health threats and adopt behaviors that promote good health. So, for instance, diabetes, heart disease, smoking, these are all, they work for these diseases, these campaigns. There are many current health issues that we have within the UK. So, there's obesity, there's diabetes, coronavirus, at the moment not very active, but it was there. There's health, heart diseases, and increasing age groups. So all of these diseases, most of the time, they impact this increasing age population. So the longer people are living, problem with a longer life is that they're not they're prone to have all of these diseases, most of these diseases, and the impact of infections like viruses like coronavirus may be even harsher in them compared to people who are of a younger age group. So let's talk about obesity in the UK. So the Health Survey for England 2019 estimates that 58% of adults in England are obese, which is a big percentage, and a further 36.2% are overweight but not obese. So obesity is defined as someone having a body mass index or BMI of 30 or above, and BMI between 25 and 30 is classified as overweight. This is for an adult. There was a survey that found that men are more likely than women to be overweight or obese. 68% of the survey said for men, while there were 60% of women who were obese or overweight. People aged 45 to 74 are more likely to be overweight or obese. The reason is very clear, obviously, because they become less mobile, they become less physically active. That is why they're more prone to develop these conditions. And then childhood obesity is also very common in England, this part of the world. 9.9% of children aged 4 to 5 are obese, with a further 13% of being overweight at the age of 10 to 11 years. Year 6, 21% are obese and 14% are overweight. This data is gathered as part of the National Diet Measurement Program. And then you have diabetes. So around 90% of people who have diabetes, most of them have type 2 diabetes. Type 1 diabetes is more common in, it's found in young people. Type 2 diabetes is in older people. It can be there in young people also, but there's one that by like as a child you develop, that's type 1 diabetes, whereas type 2 diabetes is more because of the environment. So 8% of people with diabetes have type 1. So about 2% of people with diabetes have a rare type of diabetes. So more than 4.9 million people have diabetes. This is again because of the lifestyle factors, aging population, a lack of physical activity, old, yeah. So 13.6 million people are now at an increased risk of type 2 diabetes. In the UK, you're more at risk of type 2 diabetes. You have a close family member that makes your genetics also there who has diabetes. So around 0.8 million people are currently living with type 2 diabetes, but they are yet to be diagnosed. So the people who are there, data hasn't been shown because because they don't know their diabetic status. Research has shown that for some people, combined lifestyle interventions, including diet, physical activity, sustained weight loss, can be reducing the risk of type 2 diabetes by 50%, which is a huge percentage. And then we have heart diseases. So these conditions are called non-communicable or chronic diseases. So they mostly tend to happen together. Like if you are a diabetic, you might have hypertension, you might have heart diseases. And if you are a heart patient, you might have diabetes, you might have other conditions also. Mostly diabetes and heart disease hand in hand. Because diabetes itself, when it happens, it affects vessels of your that carry blood in your body. So if those are impacted, you would be having more heart diseases. So the term heart diseases, it's often used interchangeably with cardiovascular disease, or CVDs, or heart disease, same condition. So cardiovascular disease refers to conditions that involve narrowed or blocked blood vessels. These can lead to a heart attack, chest pain, which is angina or stroke. Heart and circulatory diseases cause a quarter of all deaths in the UK. That's more than 1.1 million deaths each year. So an average of 460 deaths each day, or every 3 minutes, one in every 3 minutes in the UK. So these are around there are around 7.6 million people living with a heart disease or a circulatory disease in the UK, 4 million men and 3.6 million women. So again, we say men are there higher because obviously if they have higher chances of being obese or overweight, they would have all of these conditions more common in them compared to the women. In the UK, there are more than 100,000 hospital admissions every year due to heart attacks alone. That's one every 5 minutes. And then we have increasing age population, which again is a big issue. So in the mid 2014, the average age exceeded 40 for the first time. So by 2040, nearly 1 in 7 people are projected aged over 75 years. This is a demographic shift, it's a demographic change. Demography is the study of populations. So this will impact the whole country, go old in a society where there are more people who are young and fundamentally different to doing so in a society where more people are in the older age groups. So it has implications for how each of us approaches and plans for our own old age and for the old age of our family members. So if there are no significant improvements in health, UK population aging will increase the amount of ill health and disability. Obviously, there'll be more disabled people, there'll be more ill people with increasing age, there'll be chronic conditions. So more of the finances, obviously, and more of resources will go to treat them, to prevent their illnesses, or to rehabilitate them, rather than working on younger people. So that is also going to be a problem that is foreseen. So chronic conditions, multimorbidities, and cognitive impairments will be more common. At the same time, families will face increasing pressure to balance care with other responsibilities, particularly work. And then coronavirus. So the King's Fund, in partnership with the Health Foundation, it's undertaking a project to explore the local response and recovery from COVID-19 pandemic. This research will capture a cross-section of experiences of directors of public health and of wider local leaders in managing the pandemic, both in terms of the immediate impact of COVID-19 pandemic and its wider impact on the local systems. For instance, there were closure of schools, there were housing problems, there were local economies that went really down. So there's some campaigns to address current public health issues. So there's within the UK. So there's Change for Life. It's a UK government initiative that helps to improve diet and fitness levels amongst the UK population. There's the National Flu Immunization Program that's launched in 2021 to 22. Influenza vaccine or flu jabs are given through this.
this was a campaign that was COVID vaccination programs was it's an ongoing mass immunization campaign for COVID 2019 within the UK. A lot of its vaccines are now being withdrawn because of adverse effects. So what has changed for life? Eat well, move more, live longer. That's their theory. So the campaign is supported by the Department of Health, DOH, and intends to target the growing problem of obesity in a very hands-on, positive way by instilling healthy eating and exercise habits into people from a very young age. So the idea is that good eating habits that are formed early in life, they'll be carried forward into adulthood. That's mostly the cases, but sometimes it's not. Sometimes you're hit by some situation that may not make life the same for you, but otherwise you would most likely be the same throughout your life. So the campaign slogan is eat well, move more, live longer. It's a simple message that's been designed to create a holistic approach to weight and health problems, aims to encourage individuals to address all areas of their lifestyle with regard to safeguarding their future health and well-being and that of their children. And the National Flu Immunization Program, it's flu shots or flu jabs. They're vaccines that protect against infections by influenza viruses. They're newer versions of vaccines that are developed twice a year because the strain of the virus also changes, so they need to be developed regularly. And then their effectiveness varies from year to year. Most provide more high protection against influenza, especially for people who are more vulnerable of older age or very younger age. Into immunized people and also people who work, who are health workers, they also need these immunizations. So immunized workers who do catch the flu return to work half a day sooner than on average. So they even they're hit by the flu virus, they're not hit that bad compared to someone who's not had the vaccine at all. So vaccine those over 65 years old remains uncertain due to lack of high quality research. Vaccinating children may protect those around them. COVID-19 program, obviously, in 2019, it was mass immunization campaign within the UK. So the UK's vaccination rollout was the world's first mass immunization program for the disease, which began on 8th of December 2020 after Margaret Keenan received her first dose of two vaccines. As of 12 September 2021, there's been a lot of doses. So first doses are around 48 million, and then 44 million, the second dose of vaccine has been administered across the UK. So this is what we looked at today. We looked at equality of access to health and social care within your chosen country, current public health issues within your chosen country, current issues in the provision of health and social care within your chosen country, and campaigns to address current public health issues. These are the references that you should be going through just to have a better understanding and for your assessments. Yeah, that's about it. Any questions?
Thanks very much. Thanks for your time. It's well explained. For me, I do not have any questions. Thank you.
Okay. Thank you so much for your comments. Yeah. Anyone else?
It's well understood. Thank you very much.
That's okay. I'm glad you understood it. I'll stop sharing this. So we will be having a discussion, as I just mentioned earlier, the 18th of Saturday, that will be Saturday. I cannot wait for very
Your line is fainting. I can't get what you just said now.
Yeah. The 18th of May, we'll have this discussion on your assignment. So I might just give a very brief overview of what we have studied so far, the 4 learning objectives, but very fast and very superficial. I won't go deep into it, but it's worth attending the session. And if you have any questions, we can address them there. Okay.
When is that? Are you doing that now?
No, I don't have that's not, it's on the 18th of May. It's on Saturday.
Oh, no, yeah, that's fine.
Okay, okay, that's fine.
Okay.
Thank you very
So,
much.
yeah, that's okay. Good luck to all of you, and I hope you have a lovely and safe week. I'll see you next Saturday.
All right, see you.
See you. Bye.
Bye.
Bye. Thank you.
Thank you. Bye.